Good morning, everyone, and thank you for joining us today. My name is Alma Ahmovic. I'm part of the student network team, and I will be hosting today's webinar. So today, the webinar is going to last approximately 1 hour, and we will have some time at the end for questions and answers. As you probably know, you're all muted. However, there is a questions box on the panel. So if you do have any questions, please type them in, and then I will ask them at the end of the presentation. So our presenter for today is Sue McGarrigle. Sue is a clinical nutritional therapist and a naturopath, and she has practiced since 2001. She is a lecturer to college and university students all the way up to the master's level. Sue has trained hundreds of healthcare and medical practitioners in many aspects of nutritional therapy. She's also a regular contributor of specialist nutrition articles for magazines and newspapers, and has been a guest speaker at national level. Sue is a member of BANT Professional Practice Committee as well. So today's webinar is entitled The Role of DHA in the Cardiovascular System. This lecture will look at the specific protective effect of DHA within the cardiovascular system and the mechanisms involved, plus the effects of numerous non-conventional risk factors which are not routinely measured. So I'm very much looking forward to this webinar, and without further ado, it is my pleasure to introduce to you our presenter, Sue. So Sue, please welcome.
Thank you very much. Welcome everybody, and it's my pleasure to go through some insights with you into the role of DHA in the cardiovascular system. So having a look at the considerations to begin with, population studies have indicated to us that there's very much a low level or low ratio of omega-3 to omega-6, and this combined in blood lipids at significantly greater risk for coronary heart disease, ischemic events and sudden cardiac death. The problem we have with the Western diet is that the ratio of omega-6 to omega-3 should be around 1:1, but it can be anything up to as bad as 30:1, and this can cause an increase in arachidonic acid, because if you go back to basics, you've got two pathways of essential fats, which is omega-3 and omega-6. And omega-6 competes with omega-3 and can use up the enzyme pathways, which then, if you have a predominance of omega-6, as you all appreciate, can cause excess arachidonic acid. And although we do need arachidonic acid because it's pro-inflammatory, the problem is that we can get chronic inflammation, so this can cause problems. So normalizing the O3 to O6 ratio will provide cardioprotection. Not that it's all about inflammation, although inflammation is very key. There are other factors involved. And I had a look at the recent statistics, which you probably, like me, find a bit horrifying. Every 7 minutes, someone in the UK will have a heart attack. Every 12 minutes, someone in the UK will have a stroke. And over half of all adults in England have raised cholesterol. I think you appreciate that we have a real problem in the UK with fat intake, sugar intake, and overall CVD is estimated to cost the UK economy £19 billion, which I've given you the breakdown there of the statistics. So according to the World Health Authority, we have 8 key risk factors, and I think we see this walking through our clinic doors very regularly, where you've got high body mass, blood pressure which isn't normal, high cholesterol, high blood glucose, low fruit and veg intake, and physical inactivity. And this can account for as much as 61% of all cardiovascular deaths and over 3/4 of all CHD, the leading cause of death worldwide. So looking at DHA, which is below EPA in the omega-3 chain, It's an omega-3 fatty acid that is a primary structural component of the human brain, cerebral cortex, skin, and the retina. It's very, very important. And figures show through the Nutrition Foundation that we're very much depleted in DHA. And it's either obtained from the diet, but you probably, again, know that a lot of people don't eat the dark, oily fish, which is where we can get it from. It could be synthesized from alpha-linolenic acid, which a good example of that is flaxseed. It can be obtained directly from the maternal milk or algae. It can be converted in small amounts from EPA, but it depends on various factors, which I'll go through in a moment, whether that can happen or not. And there is a double shunt there. It's called Sprecher's shunt, if you ever want to look at that, where EPA can make small amounts of DHA, but conversely, if you're taking enough DHA, then you can also make EPA as well. And there's been a lot of research on DHA specific heart protective effects. For many, many years now, fish oil has been looked at in research with the combination of the two, DHA and EPA. But now they're splitting the two up so that they're looking specifically how DHA works, how EPA works, and the combination of the two together, which is quite interesting. So going back to alpha-linolenic acid, using the example as flaxseed oil, there are some individuals who are more efficient at converting it ultimately to DHA, but there's quite a few steps in that pathway. But the majority of Westerners are poor converters, and adults and children alike who follow a low-fat, low-fish diet often miss out on beneficial long-chain polyunsaturated fatty acids. Factors I've put in here include a lack of vitamins such as B3, B6 and C, minerals, zinc and magnesium. And I think with all the types of stress that people are subject to on a daily basis, that one of the main deficiencies we do see is magnesium, and that is pretty crucial alongside zinc for conversion. So you can get a lack of enzymes through competition. Omega-6 compete for the same enzymes in the synthesis of these longer polyunsaturated fatty acids, such as arachidonic acid and EPA, and unfortunately omega-6 usually wins out, or arachidonic acid, its substrate, usually wins out over DHA and EPA. So with the explosion of everybody eating a lot of margarines and omega-6, this results in greater net formation of this pro-inflammatory arachidonic acid than EPA. And this can also happen in aging. Now, looking and going into the cardiovascular side of things, dyslipidemia, this is elevation of plasma cholesterol, triglycerides, the fats, or both, or a low high density lipoprotein level, or HDL, which is commonly known as the good cholesterol. And this contributes to the development of atherosclerosis. Causes may be primary, genetic, or secondary, and the current diagnosis is by measuring plasma levels of total cholesterol. But this really is not the ideal way to see whether somebody is prone to, or going to be prone and have a risk of atherosclerosis, and we will go into this in more detail. So LDL cholesterol, low density lipoprotein cholesterol, we do need it. It performs a number of vital functions. Studies show that the size of LDL, when small and dense, has a threefold greater risk of coronary heart disease. So what we need is the big, as they call it, the big fluffy sized molecules of LDL, which aren't going to penetrate the epithelial or arterial wall. And atherogenicity is attributed to its ability to enter blood vessel walls faster than these larger LDL particles, and they have a lower binding affinity for the LDL receptor, and its increased susceptibility to oxidation. And one of the things that is really good for stopping oxidation of LDL small molecules is EPA. It's like the sweeper, which helps to stop that oxidation, which is causing problems on the arterial wall. And despite aggressive statin therapy to reduce LDL, other factors definitely contribute to residual risk other than LDL and particle size. There are other components within lipoproteins, and these other than non-HDL, and these are very low density lipoprotein molecules called VLDL or VLDL remnants, and something called lipoprotein A. So you can see here that a picture of scales where we've got large molecules on the left and where we've got far more particles on the right, because they're a lot smaller. So the large LDL doesn't pose a risk of heart disease because this doesn't penetrate the walls of the arteries or the other blood vessels, whereas on the right hand side you've got these much smaller particles, small LDL, and normally this is caused by the LDL cholesterol being made up of far too many fats or triglycerides, so there's not much room for any cholesterol. And because the cholesterol needs to be carried around the body, then you're going to get far more of these little particles which are trying to clear the cholesterol. So this is where we see the cholesterol balance. And it's no good just measuring the amount of cholesterol, as I said before, because that's not going to give you how many particles there are, which is the more of a bigger indicator as to risk. Something called ApoB, which is a marker for LDL particle number, or as it's called, LDLP for particle. It's also a marker for very low density lipoproteins and the intermediate one as well, IDL. So cardiovascular risk is associated more with the number and size of circulating atherogenic particles than with the concentration of cholesterol in these particles. And because all these very low density particles or cholesterols are considered atherogenic, the ApoB level should reflect the atherogenic potential of these lipoproteins. So testing for ApoB and LDLP is going to give you a much better picture of the cardiac potential within a client. They do routinely, if somebody is referred to a consultant, a cardiac consultant in the hospital, then they tend to test for these levels. So what it comes down to is individuals with a high LDL cholesterol but a low LDL particle in number are not at high risk of heart disease. Blood levels of small dense LDL increase with elevated triglycerides and pose a risk for development and heart attacks. Small dense LDL is more susceptible to oxidation and more atherogenic. Small dense LDL contains more arachidonic acid, which, as I said before, is pro-inflammatory. Small dense LDL is also associated with insulin resistance. And DHA lowers triglycerides and small dense particles of LDL cholesterol. It increases the particle size, so it makes them big and fluffy again, which may in part explain why you see this initial rise in LDL cholesterol when someone starts taking DHA. But it's a good thing because it's increasing that particle size. So it doesn't matter that it's going up slightly. And EPA preferentially inhibits LDL oxidation and it aids the clearance. On the other side of the coin, DHA significantly raises HDL, and HDL is antioxidant and anti-inflammatory, and it also reduces something called macrophages, which I'll come on to shortly. So overall, DHA supplementation reduces the concentrations of atherogenic lipids and lipoproteins and increases concentrations of the cardioprotective lipoproteins, HDL. The problem with statins is that they affect serum polyunsaturated fatty acid levels, and they increase the ratio of arachidonic acid over EPA, and this is a measure of cellular inflammation. Statins also decrease DHA, giving an increased arachidonic acid to DHA ratio, showing dyslipidemia. A lot of people can't take statins because it makes them feel very tired, particularly in the afternoons. They also cause joint pains, and they decrease CoQ10. And it's found that about 62% give up due to side effects. I see this quite commonly. Now, the factors, of course, for cholesterol, smoking, obesity, a diet high in sugar and low in fermented dairy products were associated with an unfavorable apolipoprotein profile. And I think you'll all agree that a lot of our clients will come in, they may be overweight, and what's missing in our diets, just apart from fruit and vegetables, is the fermented foods, the bitters, hydration, the polyunsaturated fatty acids. There's so much that's missing on a daily basis, and also the diversity of what people are eating. They're not eating a range of fruit and vegetables. They might just be restricting themselves to one or two. And that's not good either, of course, from the point of view of polyphenols, which are so important, and they are absorbed, and there are different types from various vegetables which need to be eaten on a daily basis. And where we used to eat hundreds of diverse foods, we're now down to a very small profile of various foods in the UK. ApoB seems to be a very important parameter in assessing cardiovascular risk now, and particularly also in the setting of diabetes and metabolic syndrome, since patients with these conditions tend to have small, dense LDL particles, but they will show a normal LDL. Now, you can have a normal LDL, but if you have these small, dense particles with high ApoB levels, that's giving you the risk. So it's very important. We just don't go on the total cholesterol assessment alone. Now, EPA and DHA significantly lower in vivo oxidative stress in hypertensive diabetics and in dyslipidemic men. The degree to which they do this appears to be comparable and associated with a change in TNF-alpha concentration, consistent with a link between inflammation and oxidative stress. In diabetics, and we see an awful lot of this now, this is a big problem in the UK, particularly late onset diabetes 2, there is increased oxidative stress due to hyperglycemia, as well as increased lipoprotein oxidation and glycolysis. So again, this group is at higher risk of elevated inflammatory biomarkers, which are associated with increased risk of atherosclerosis and plaque rupture. And it's the plaque rupture which, of course, gives you the onset of a heart attack. And there are different types of plaque. You may have plaque and they may be stable, or you may have unstable plaque, and we'll be looking at that as well. So in diabetes 2, here's a paper for you, and I've also attached a very full list of references with this presentation notes for you, so that if you want to look into anything in more detail, then you can do. That's no problem at all. So this is a good paper. A supplementation with DHA increases LDL particle size, reduces serum triglycerides, and increases, excuse me, just having a quick glug of water there, and increases HDL cholesterol, as well as improves vascular function and blood pressure. Therefore, for subjects with type 2 diabetes, DHA may have more therapeutic value than EPA as a food additive. So unless people are eating dark oily fish or algae, then if they're not converting enough omega-3, and particularly right down the pathway to DHA, they must either start eating these foods, or they must have a supplement. So what we're looking for is reduction of small LDL, reduction of oxidation, reduction of inflammation. And recent evidence also suggests a stabilizing influence of fish oil on pre-existing atherosclerotic plaques, and we'll have a look at that too. So there's a very good paper which I've put down the bottom there for you from Calder, but also T-Sess et al. Demonstrated that atherosclerotic plaques from patients treated with fish oil were less heavily infiltrated with macrophages. And macrophages, that you're going to get cellular changes, and plaques from patients treated with fish oil were more likely to be fibrous cap atheromas. This is a type 4 plaque, and this is considered more resistant to rupture. So fish oil does have a very stabilizing effect. People tend to have thin inflamed cap atheromas, or the type 5 plaque were found that these can rupture a lot more easily. And you'll find in these thin inflamed cap atheromas, inflammatory cells, macrophages, T cells, mast cells. They're very abundant at these sites, and these cells produce a range of mediators and enzymes that thin and weaken the cap, making it very vulnerable and unstable. So DHA and EPA will help to stabilize them. And most randomized placebo-controlled trials have used a mix of EPA and DHA, or investigated only one. But now what's being found, a meta-analysis, is that DHA has a more significant impact on lowering triglycerides than EPA, so very important. And there's nothing wrong with giving people standard fish oil supplements, which are usually in a ratio of 3 to 2, which will have positive effects on heart health and also a range of other health benefits within the body. But they found now that DHA rather than EPA is preferentially incorporated into the myocardial cell membrane. And this influences the beta adrenergic system to a greater extent than EPA. So this is influencing certain hormones, which is another important mechanism involved in hypertension, because the hormones can constrict the blood vessels, of course, that you can get arrhythmia. And so DHA is good in influencing that system and having an anti-arrhythmic action. Additionally, DHA stimulates release of ATP, increasing vasodilation, which stimulates nitric oxide, which opens up the blood vessels. So a combination of this and the decrease in noradrenaline levels has a blood pressure lowering effect. Another meta-analysis showed that prolonged fish oil intake may reduce heart rate. So people who get fast heart rhythm, who have a high baseline heart rate, in dyslipidemic males, and of course postmenopausal women, they have to be careful about looking after their heart. This decrease appeared to be mediated by DHA rather than EPA. So DHA, as far as the heart goes, very, very important that we lower triglyceride or fat levels, HDL cholesterol, blood viscosity, blood platelet reactivity, other thrombogenic risk factors, and also that surge you get after a carbohydrate meal. You get these blood fat surges, so postprandial lipemia, it will help with that. Heart rate variability, reduction of arrhythmia, arterial compliance, and also because they help to open the blood vessels, you'll get an improved left ventricular filling. So quite a lot there that you can influence through using DHA with some EPA as well. So DHA modulates a number of risk factors: triglycerides, HDL cholesterol, LDL particle size, heart rate, blood pressure, inflammatory markers, and vascular function more favourably than EPA. I'm not putting EPA down because EPA is very, very important indeed, especially on the anti-inflammatory and antioxidant front. This is a lovely paper. I thought I'd just pop this one in for you alongside the list that I've sent through anyway. But this really does go into all these differential effects of the two on cardiometabolic risk. So if any of you suffer from insomnia, then I would definitely recommend this paper to you. It goes on and on and on. It's fascinating, actually, if you've got time to read it. And also with stroke, most evidence suggests a reduced risk of stroke associated with high dietary fish consumption, particularly in elderly people, and following standard dose response of omega-3 fatty acids and particularly DHA. And unfortunately, proton pump inhibitors, so the ones that are used for acid reflux, like omeprazole, lansoprazole as examples, they're now showing to increase risk of heart attack, dementia, and stroke. And there's a lot of people in this country that are put onto PPIs, and a lot of people I hear through the practitioners that some people have been on PPIs for years, and that's not good at all. So let's just have a look at inflammation, because this is a very key part of everything, all disease, but particularly for the heart and the cardiovascular system. Subclinical inflammation is recognized as a key etiological factor in the development of atherosclerosis that leads to ischemic heart disease. And there are two distinct phases of inflammation: initiation and resolution. And these are both active processes that operate independently. If they are mismatched, the result is continuing low-level chronic inflammation below the perception of pain. So in other words, you can have silent inflammation going on, or you'll have cellular inflammation that actually contributes to the build-up of atherosclerotic lesions and their rupture that leads to the mortality from heart disease. And plaque, of course, or the lesions are full of these fatty deposits and a lot of cellular debris, blood clotting material, and the small, low density cholesterol, which then penetrates through and builds up on the blood vessel walls. So a keystone to resolving inflammation, if you remember, I said that macrophages are involved in inflammation, and they can contribute to plaque, which can rupture. But resolution of inflammation has historically been viewed as a passive process occurring as a result of the withdrawal of pro-inflammatory signals. So it's always been a singular approach: one drug or anti-inflammatories, maybe nutrition, including lipid mediators such as leukotrienes and prostaglandins in this withdrawal. And most anti-inflammatory drugs just target these primary mediator pathways that are engaged at the onset of inflammation. Only recently has it been established that inflammation resolution is an active process with a distinct set of chemical mediators. And surprise, surprise, this is very much to do with DHA and EPA. So while studying acute inflammation in animals, scientists noticed the production of small molecules released in response to inflammation, especially in the presence of high levels of the omega-3 fats. And the first of these pro-resolution molecules which they've identified are lipoxins, and then they found some which they've named resolvins and also protectins. And what these molecules do, first they send out a stop signal and they put a stop to runaway inflammation, and then they trigger the active resolution of inflammation. And they're able to resolve inflammation associated with atherosclerosis mainly by downregulating the expression of inflammatory proteins that you can see there, MCP1 and IL-8. Now, each of these molecules provides different but overlapping functions in actively resolving acute inflammation. Beneficial lipoxins are formed from arachidonic acid, but they do require high omega-3 concentrations for their production. And I've put a paper down the bottom there for you if you want to have a look at this in more detail. Oh, got a blank slide there. There we are. Because I'll just check. Okay. Because atherosclerosis is a low-grade systemic inflammatory condition, it is likely that reduced formation of all these molecules, and there's some called marasins, which you can only get from DHA, and these play a significant role in its pathogenesis. So resolvins are anti-inflammatory and also immunoregulatory products of the metabolism of DHA and EPA. And EPA produces E-series resolvins, DHA produces D-series resolvins, and these do different jobs. So these have provided a new basis for the health benefits of DHA in the resolution of inflammation, tissue injury and wound healing. So protectins formed only by DHA prevent inflammation by blocking neutrophils such as TNF-alpha and altering COX-2 activity. So also we've got resolving E1, EPA, very important, and resolving D2 from DHA. They tend to help block TNF-alpha from inducing pain. Now, fish oil's multiple benefits have long been attributed to its effects on reducing inflammation. We all know that. And we know that aging produces a total body loss of these health-promoting molecules. It may be more difficult to reach the necessary omega-3 fatty acid levels to generate adequate levels of anti-inflammatory molecules within the modern day diet. So it's very important, therefore, as I said before, that we may need to supplement. So I've just put a few other bits and pieces in here for you, whereby you might find that using DHA has effects elsewhere. And DHA, mitochondrial function, they have a substantial concentration of DHA containing phospholipids, and these are essential for the functional assembly of the respiratory chain complexes. So in other words, energy production. So pretty important. And you might want to look at this because, again, DHA is very important for the brain. We have to make sure that circulation is not just good for the heart, of course, but throughout the whole body. And with so many people eating such a poor diet and so much sugar, of course, without a proper fat intake. And they found at Massachusetts Institute of Technology that a clinical trial of an Alzheimer's disease treatment, they've been using this cocktail of 3 nutrients, which is helping to improve memory in patients with early Alzheimer's dementia. And this is very much a thing that's going on with DHA at the moment. Interestingly enough, in Canada, they're running trials with DHA and finding that it's reducing the amount of seizures in epilepsy, and that's ongoing. And what they're finding with the brain is that in dementia, that it's confirming that the DHA is helping with, alongside these other 2 nutrients, to promote new connections between the brain cells. We all know Alzheimer's patients gradually lose those connections, the synapses, leading to memory loss and other cognitive impairments. And what they've been using is choline, uridine, and DHA. And choline can be found in a variety of dietary sources. Omega-3, of course, we've looked at that. And uridine is naturally produced by the liver and kidney and is present in some foods as a component of RNA. So these nutrients are precursors to the lipid molecules which make up brain cell membranes, which form synapses. And to be effective, they need to be administered together. We know there's a lot of factors involved in Alzheimer's, and principally what we do as nutritional therapists, diet, exercise, supplements, hydration, etc., all goes towards helping in early onset of these disorders. And you might find this interesting, excuse me. There was a review in January 17th, 2017, and this is all to do with a genetic allele called ApoE. And this is involved under the influence of DHA to slow the progression of dementia. So if you're interested in that, I've put the paper on here for you to have a look at. So BioNutri do a fish oil which has more DHA than EPA, and as I said before, if you need more EPA, then it can be made from the DHA. And as some people struggle to make enough DHA, then DHA, the liver is involved as well in DHA production. So we've turned everything on its head, and we have produced a fish oil which is in a 5:1 ratio. And this is the same ratio that you get or see in tuna fish. We don't make ours from tuna, we actually make ours from Pacific anchovy and sardine. But it's very important, we feel, that we have more DHA now for a variety of reasons than EPA, not just for the cardiovascular system, but it's universally needed in neurological tissues, and certainly it's very useful as part of the major structural component of the brain tissue and nervous system. A lot of research has been going on as to the role of DHA in the brain, so do have a look at that if it's of interest to you. They're finding that people who, for instance, have sporting injuries, that they're far more likely to recover from a head injury if they've got enough DHA in the system. And DHA, as I said, is critical to the formation of neuronal synapses and membrane fluidity, cognition, maintenance of brain and eye health. There's a lot of it in the retina. It's predominant in the cardiac cells, cardiovascular health, for inflammation. For fetal and adult immune health, they're finding that mums who have been on DHA prior to becoming pregnant, all through pregnancy and through breastfeeding, it's really stood the baby in good stead, not just for cognition and for learning, but also for immune health. And they did some big studies to see that a lot of babies who'd had DHA-rich milk or were given it during their early life certainly had fewer colds and other immune episodes. Also, they've just found, for your interest, that DHA is very, very good for sperm health. It's actually needed to make the architecture or the acrosome of the head of the sperm, and so it's pretty crucial for fertility. So that's just a quick look for you at what DHA is used for, but there's a lot more, but I've put the major bullets on there for you. So we all know that diet, lack of fibre, stress, blood pressure, genetics to a certain extent, alcohol and smoking can cause cardiovascular problems. But if as nutritional therapists we correct this, and of course, even if somebody has a weakness in their genetics, that doesn't mean to say that it's going to be expressed. So there's an awful lot you can do through food and through supplements to influence that side of things. So very important that we have enough fish. And of course, we used to eat plenty of fish, and particularly the dark oily fish, as I said. But when I was doing clinics, I never saw on the questionnaires, I don't think I ever saw dark oily fish. Maybe kids ate fish fingers, and maybe some people had cod maybe once a week. Occasionally I saw a piece of salmon appear on a questionnaire, dietary, but nuts and other healthy oil containing foods, seeds, etc., they were very deficient in the diets, and also the fruits and vegetables, which is so important. So multiple studies reveal that supplementing with omega-3, it does boost production of pro-resolution molecules and quickly brings your body back to a non-inflamed state. And it's interesting that deficiencies in these pro-resolution molecules have been identified in most of the chronic inflammation-related diseases of aging. I think if one focuses on the GI tract and the beneficial bacteria and getting the balance right there, and also inflammation, and this in turn will affect immunity, of course. And a lot of human clinical trials demonstrate anti-inflammatory effects of fish oil supplementation in metabolic syndrome, which we see a lot of, cardiovascular disease, lung diseases, neurodegenerative conditions, and cancer. And there's evidence flowing in daily for all these diseases. And I personally think that fish oil can no longer be considered an optional supplement. Rather, it's a must-have for the prevention of the inflammatory conditions of aging, because that food has just disappeared along with the other ones that I mentioned earlier, like the fermented foods and the bitters. So very, very important. There are foods that will help with clearance of the arteries, things like avocados, broccoli, nuts, olive oil, brown rice, quinoa, and we all know the benefits of the Mediterranean diet in particular, which is great for the cardiovascular system. So I think looking at that, as nutritional therapists, we can do so much. So that's the end of the presentation. I've finished up a little bit early, but if anybody has any questions, thank you for listening. And if you have anything that you think of that you might want to ask me at a later date, then you can always find me on my email, which is suem, S-U-E-M, at bionutri.co.uk. But I'll hand back over to Alma and see if there's any questions to be asked.
Hi, Sue. Thank you so much for that presentation. It was really, really interesting, very useful as well. We have a few questions. So one question is, if a client is taking medication for an autoimmune condition, and one of the side effects of the medication is raised cholesterol, is it possible to alter or lower the cholesterol levels via diet or supplementation?
I would do both, actually. The medication that you've just got to be really careful with, obviously with DHA and EPA, is warfarin. It's the blood thinners. So you're looking at warfarin, garlic, vitamin E, these sort of things. You've just got to be a little careful. To be quite honest, I mean, I've seen patients who have taken fish oils and then gone on to drugs afterwards and have had no effects. I think you just have to be careful when they go on to drugs, and then you've got to put them on fish oils afterwards. But you can always get GP approval if you want to do that. But I can't see a problem with taking fish oil. It depends on the medication. But if you wanted me to do a thorough check and give me the name of the medication, then I could give you a definitive answer on that, and you can email me. That's no problem at all.
Oh, thank you, Sue. That's really helpful for you. The other question is, somebody says that most fish oil supplements have a much higher ratio of EPA to DHA. So are there any that you favor in clinical practice? So I know that you've mentioned the BioNutri one. Maybe you can tell us.
My personal view, as a naturopath, is that you should always take any fish oil if you're going to supplement rather than eating the food, and it should be never go outside the ratio of the fish. And there has been research which demonstrates if you have too much EPA, then that will affect the immune system. And for me, as a naturopath again, I will always say, do what you can with food. If you have to take a supplement, then don't use a singular approach. Don't use an isolated approach, in other words, high dose of an isolate, because although you may be initiating a pathway which is going to improve, it will be to the detriment of something else. And there is definite evidence now that too much EPA will affect the immune system.
And would you, before recommending supplementation, would you test first? And if so, which test would you recommend?
You can do. I mean, Biolab do the tests. They test for the pools of the fatty acids, and it will give you an idea. I did speak to Mark at Biolab about this, and I said to him a while back, actually, I said, what sort of results do you see? And he said, oh, I always see that people are low in the essential fats. And I think going on diet, if you have a look at somebody's diet on a questionnaire, if it's not there, then you can assume that they will be deficient, because about 80% of the population are deficient in omega-3.
And I just wanted to ask you, the ratio DHA to EPA that you mentioned in the BioNutri product,
Yeah.
would you recommend that mainly for cardiovascular issues, or would you generally recommend a product with higher
I would generally, yes, I would generally recommend a higher DHA product, which is why we are making it higher. Because if you have a higher EPA product, I mean, as I said, most fish oils are EPA to DHA 3:2, which is fine, but a lot of people are not getting enough DHA because of what's a lot of factors in the body. It depends on the individual, but what we're finding is that if you go in right down the bottom, at the bottom of the omega-3 pathway, and give the DHA, at least you can make EPA from it. The problem with EPA is if you're not getting much DHA, EPA is not going to make a lot of DHA. It'll only make small amounts. So looking at all the new research, particularly on the cardiovascular side, and some of the other stuff, which is the fertility, the brain, etc., pregnancy, immune, our feeling is that you need a higher DHA product, and other companies are now following suit as well. And although if you look at the 5:1 ratio, which I said is what you find in tuna, if you look at the Japanese population...
So I've lost your audio. I don't know if you're still there.
Hello?
Who?
Hello?
Sorry, I've lost you there. I think it was, I don't know what happened with some technical issues, but I've lost you as you started to answer that question. So do you mind repeating? You were saying that about DHA and EPA and how you could make some some EPA from DHA, but if you go just
Yeah,
EPA,
if you look at the pathway, EPA, if you take foods which provide EPA, you will provide a small amount from EPA of DHA, not large amounts, just small amounts. So it's better, we feel, that you have a higher amount of DHA from which you make EPA, because there's a double shunt at the bottom of that pathway. And also people aren't getting as much DHA as they should be. So because of diet and because of other factors. So if you look at the Japanese population, our DHA formula is 5:1, and other companies are following suit now, based on all the new information coming out about DHA and the cardiovascular system, the fertility, for fetal health, for the brain and cognition and everything else. So we feel that a higher DHA product, it's better to go in with the right amount of DHA, and then if EPA is needed, then you'll get that from the DHA and from the amount that's in there in a product, and from oily fish anyway. But we know that so many people don't eat dark oily fish. They might have a piece of salmon or something. So if you look at the Japanese population, they eat a lot of tuna, which is that 5:1 ratio. So you have DHA to EPA 5:1. And of course, they have a very high IQ. So it's good to have a lot of DHA for the brain.
Great. And if you are trying to get the adequate levels of DHA with food, what would this look like? For example, somebody's asking, is it oily fish 3 times a week, nuts and seeds every day?
Yes, yeah, about 2 to 3 portions a week would be great. But you would need to have DHA-rich fish like tuna, because every ratio in every fish is different.
Okay, and because of the mercury toxicity scare, is there any other fish that you would recommend? What else would you consider? Is it
well, if you want to diminish mercury, you eat the smallest fish you can, because they're less infected with mercury. With supplements, if you're bothered about mercury, then just have a small amount of dark oily fish and you could supplement. All fish oil supplements are screened these days, and you will have minimal levels of contaminants in them. You'll never find an oil that has no contaminants, but there'll be next to nothing in them.
Okay, brilliant. And the last question is that it says you mentioned that the use of DHA in the treatment of epilepsy. I think you said there was some Canadian research. Please, do you have the paper details?
Yes, I'll have to email it to you. Sorry, I haven't got it to hand.
Okay.
But if anybody wants to look, I think it comes up quite easily if you just put into Google Canada DHA epilepsy. I think it will probably come up.
Brilliant. And also, I just want to remind everybody that all the recording of the webinar, as well as the slides that Sue has presented, will be put on the BANT website under the student section within a week of this presentation. So you will be able to download and read through and check all the references that Sue mentioned.
Yes, there's I've sent a PDF of the slides if that's easier. Doesn't clog the computers up quite so much as PowerPoint.
Yes, so we do download the PDF version on the BANT website, and you can check all the previous webinars as well.
Yes.
Sue, thank you so much. That was brilliant. Really, really interesting. Thank you for taking the time out of your busy schedule to present to our
No
students.
problem at all. And I hope to see some of you maybe in the future at various
Yes,
events.
thank you very much. And I just, before we finish, I just wanted to remind everyone that our next webinar is going to be on the 23rd of May. And once again, Sue, thank you so much. And thank you
You're
to all the
welcome.
students for attending and registering. And hopefully we will welcome you again to one of the other webinars in the future.
Thank you. Thank you,
Thank
Alma.
you.
Bye,
Bye-bye,
everybody.
everyone. Have a lovely
Bye.
day.